thank you very much for joining today. I'm just going to pop my camera off because my internet is not the best today. So hopefully that's okay with everyone. But yeah, thank you very much for joining our session today on proactive data-driven care, population health management in action. So I'm going to start off, as always, with a little bit of housekeeping. So as Kirsten's popped in the chat, that your videos and microphones have been turned off while we go through this presentation. And we are going to be recording this. It will be available to view afterwards through our Digital and Transformation Network. And also, if you joined today but you haven't joined directly through a registration link, please make sure that we've got your email address and job title in the chat so that we can give you the details afterwards. Okay, so we are going to be asking questions, as Kirsten has said, through the Q&A function today. Or we're not going to be asking the questions. Hopefully you are. To use the Q&A, here's a little slide so you can see there how to submit your questions, how to upvote questions, because we will select the most voted questions to be answered live today. But again, as always, if we don't manage to get to all of the slides, all of the questions, we'll endeavour to get them answered and share them afterwards with you. Okay, so the agenda for today's session, we're going to have a think about what population health management is, why it matters, and how we can use it in practices and PCNs to move to a more proactive care model. I'll introduce you to Jeremy, Lauren and Paul to talk you through some of the risk stratification and case studies for their various services and products. And once we've been through that information, we'll open up for some questions. So if you've got any questions while we're going through this, please pop them in the Q&A and we'll get to them later. So first of all, what is population health management? So in the last 100 years, people in the UK have lived longer and healthier lives, and this is thanks to better medicine, cleaner living, vaccines and the NHS. But now more people are getting long-term illnesses like heart disease, diabetes and mental health problems. And these are often caused by things like ageing, unhealthy habits, poor housing and money worries. COVID-19 showed where our health system struggles and made problems worse for people who were already finding life hard. So population health management is about using data to understand people's needs and helping earlier before things get worse. So a recent measles outbreak where a child sadly died shows why early action matters. Vaccinations can stop serious illness, and PHM helps make sure that people get the care they need at the right time. So population health, or PHM as I refer to it, is based on three simple ideas: know, connect and prevent. So first we need to know our population, who might get ill and where people might need more help. Then we need to connect with them in the right way for the right care or support. And then most importantly, we need to try and prevent problems before they start. So PHM became part of GP contracts in 2022, but the ideas behind it aren't new. So the UK has a long history of public health work like vaccine campaigns and helping people to stop smoking. What's new now is that we can use data and technology to spot problems earlier and take action quicker. PHM and public health have the same goal: help people stay healthy and reduce unfair differences. And public health works across the whole country, but PHM helps us focus on smaller groups or individuals and give them what they need when they need it. PHM is about being smart and acting early, so we don't wait until people get really sick. It helps reduce pressure on emergency services and gives people a better chance to live well for longer. So, what does PHM look like in action, and why does it matter in general practice? Well, it matters because it helps practices to identify like I said, the right patients at the right time. By using data to spot the high risk or underserved patients early, we can then take action before those problems escalate. And that means fewer hospital admissions, fewer visits to the GP, and better patient outcomes. It also enables personalised care. So instead of a one size fits all approach, practices can tailor interventions based on patients' risk, condition, or their social needs. PHM supports better resource planning too. So predictive analytics help forecast demand, reduce those missed appointments, and they can avoid workforce bottlenecks. Most importantly, it also reduces those health inequalities by highlighting where certain groups may be getting left behind and enabling practices to respond appropriately to that. And again, it also contributes to stronger working partnerships with PCNs, ICBs, and other community services. It's aligned with the CQC and NHS priorities on prevention, sustainability, and improved outcomes. At its heart, PHM empowers teams to make data-informed decisions, not just relying on instinct, but it helps build trust with patients through a more coordinated, person-centered care, and ultimately delivers better outcomes at a lower cost. So the Neighbourhood Health Service that's just been talked about in the 10-year plan and population health management are closely linked. They do work together, but they both do different jobs. So population health management gives us information we need. It uses data to help us understand who might get sick, where people are left behind, and what health problems might be coming. And it uses tools like dashboards and predictions to find out which groups need the most help. And the Neighbourhood Health Service takes that information and puts it into action. So these are local teams made up of GPs, community nurses, housing, social care, charities, and other services. And they work together to give the right care in the right way, based on what the data and the local people say is needed. Both PHM and neighbourhood services want to stop illness before it starts and to help people live healthier lives and make things fairer. But the difference is PHM helps us understand who needs help and why, and then neighbourhood services focus on how and where to give that help. But when they work together, we don't just talk about problems, we actually fix them with care that fits in each community. So now I'm going to pass over to Jeremy, who's going to talk us through risk stratification, what it means, and how we can use it in population health management. Jeremy.
Hello, everyone. Just to introduce myself first, I've done a lot of work with primary care over the last sort of 10 to 15 years, mostly within the NHS when I was Director of Transformation at Yeovil Hospital. We were one of the vanguard sites, and we did an awful lot of work with our local practices around different care models, introducing health coaching into the practices, and really developing a kind of neighbourhood approach before the word was being used. And now my job is helping systems and teams come together as neighbourhood teams and introduce some of these population health models. So I'm currently working in Cornwall, for example, doing that with the teams down there. So enough about me. So risk stratification then, what is it to start with? So it's one of the tools that you can use under the know category, I suppose, in the previous slides, under know, connect, and so on. Risk stratification is a process for identifying and categorizing patients based on risk, usually the risk of some kind of poor health outcome, very often risk of hospital admission in the next 12 months. That's probably the most common application that we see. But it can also be used to predict the risk of other health outcomes, such as deterioration or risk of complication or progression of disease. And most importantly, then, giving you insight into some of the interventions that you might then develop to help people that the risk stratification has identified to reduce their risk, but also reducing the utilisation of health services in the future, either within primary care or within a hospital or elsewhere. So some common applications of risk stratification might be identifying people for proactive MDT review, for enhanced care planning and support, say by the neighbourhood team. So these might be people that you're already aware of, or even more usefully, it might be people that you're not necessarily aware of, might not be totally on your radar, but have been thrown up by looking at some of the data. Another example might be prioritising people for review around their long-term conditions, frailty, asthma, etc. There may be gaps in care, for example, that could be put right. There might be things like missed vaccination opportunities, those kind of things. Probably the most high-profile use of risk stratification up to now has been around reducing hospital admissions. You may have heard of the Johns Hopkins model. That's focused around predicting the risk of admission and giving you insight into which patients you might then intervene with. And this kind of thing is going to be crucial for neighbourhood teams as they come into being. But there are plenty of other models, some UK models, which I'll talk about in a little bit. And then finally, another use could be targeting preventative intervention. So identifying a group of people who might typically be at risk of, say, a fall, and then putting in place some kind of maybe group intervention or some kind of assessment, making sure they've got the right equipment, etc., to prevent that. So it can be used in a number of different scenarios. And there's a number of different ways of doing it as well, ranging from no IT inputs to very technologically and right bang up to date with AI. So the first way is just using the clinical judgment and your knowledge as the clinical team of the patients that you're working with and seeing already. And probably you already know which patients may need a bit more support, and maybe you can put a team in place and fill some of those gaps and help people get the support they need. So that's one. And then rule-based stratification is where you develop a set of criteria. So, for example, patients with more than 3 lung conditions who may be over 65 might have recently used ED more than twice, might be smokers, those kind of things, which you can then use to run searches in EMIS or System 1 or whatever to identify risks of patients. And the evidence suggests that those two models are not the most effective at identifying the right patients for making a difference to them. And then you move on to some of the more digitally driven solutions. So predictive modeling has been the kind of predominant one up to relatively recently, and that's where that Johns Hopkins model comes in that I mentioned. There's also, for example, PRISM, which is used in Wales quite a lot. And there are others that use statistics based on previous patterns, if you like, to identify patients that might be most at risk and then giving you insight to intervene with those patients. But the latest thing is, as you probably guessed, AI, which is coming into kind of every sphere. But there are systems now which are showing themselves to be very effective at predicting risk of admission. So what I'm familiar with is called Brave AI, which is being rolled out quite widely in the Southwest at the moment. And that is able to predict to quite a high degree of accuracy the patients that are most at risk of admission within the next 12 months by allocating them a complexity score. And it can run purely off primary care data, but it's even better if you can run it off some kind of linked data set. And when they've sort of tested that on historic data and then compared it with people who were actually admitted, it was pretty amazing the kind of results they were getting. So these are some of the tools that you may or may not already be aware of. So I mentioned PRISM, predictive risk stratification model. That's widely used in Wales. That's about predicting the risk of hospital admission. EMIS and System 1 have some dashboards built in. We're about to hear from Primary Care Analytics about some of their tools and how they can help you. North Central London are piloting something called Healthy Intent, which Cerner have developed, which is particularly aimed at identifying those patients who have got gaps in their care, so not receiving optimal care, where patients could benefit and utilisation could be reduced by filling those gaps. And then the AI models like Brave that I mentioned. Some things to think about: the inevitable data sharing and information governance. Obviously, if you're using your practice data only, then that's not such a concern. However, as soon as you start getting into linked data sets or using hospital data, things get a bit more complicated. And you'll probably need to enlist the help of someone in the ICB. Clinical governance and validation of patients that are selected, just kind of sense checking, making sure that by reviewing perhaps some of the individual case notes that the people being identified are appropriate. And then the training that you may need to either produce the information or interpret it. Some things to think about. So as a PCN, say, what practical steps could you take? So first of all, I think you need to be clear about what you're trying to do. Are you trying to reduce hospital admissions? Are you trying to reduce GP attendances? Are you trying to close those gaps in care, improve long-term conditions management, for example? So being clear what you're trying to do is important. And then choosing your approach, ranging from the clinical judgment purely through to the rules-based searches, through to some of the more advanced tools. Gather that data together, and then a bit of sense checking. Taking some of the patients that have been thrown up and just kind of looking at the notes and checking, are these appropriate people? Is the data actually accurate that has been used to suggest the lists? But some caution there, because part of the point of this is to highlight patients that you might not be familiar with and might be new to you. And certainly in Cornwall, where they're using Brave AI, they often find that despite what you may think, some of the patients highlighted by Brave, the GP teams are not familiar with, but when they actually go and see them, they actually do need the support. So don't rule someone out just because you don't know the name. I suppose that's what I'd say. And finally, planning the interventions. Some of the things that you would do. So, for example, is there a group of patients where you want to run a project to bring some people in and give them some extra review, bring them to the next MDT, some group interventions, all of those kinds of things. So that's all from me for now. I'm going to hand over, I think, to Lauren. Yeah.
Thanks very much. I've just got a couple of slides to do in between. Thank you, Jeremy. That was really useful. And if you've got any questions for Jeremy, please pop them in the Q&A. And that's his contact details if you wanted to get in touch with Jeremy directly. So just a couple of slides before I move on to primary care analytics is just how do we turn this stuff from insight into action? So understanding where your practices currently stand with population health management can be challenging, but you don't have to do that alone. Redmore Health D&T hubs, maturity and topic-based assessments. Each of your practices in your PCN can complete short structured evaluations, which will give you a practice level snapshot of the PHM understanding and capability within those practices. And it will give you a PCN wide average for benchmarking where you are at that moment. It gives clear visibility of variation and what gaps you have across your practices and your network. This example shown here is from Redmore PCN. So it illustrates just how you can see the different maturity levels of individual practices, and you can compare them in your PCN, helping you to pinpoint where you might need to focus your efforts first. And alongside the dashboard data from providers such as Primary Care Analytics and those that Jeremy has mentioned, you can identify trends, gaps in care and variation in outcomes. And then you can use the information from the hub knowledge base to access some tailored resources that'll help guide each practice in building the capability where it's needed the most. We have got a new continuity of care toolkit available in the D&T hub that will also help you. And then you can work as a PCN to prioritise again those common goals. You might want to you might want to improve some screening uptake. You might want to tackle some health inequalities or reduce those emergency admissions. But it helps you to visually share those insights across practices. And you can use those shared goals to align your resources, your training, and your messaging. You're also able to track your progress over time by completing the actions and repeating the topic assessments periodically. So now I'm going to hand over, is it to Lauren or Paul? Lauren.
It's to me.
Fantastic. Thank you very much.
Hi, everyone. My name is Lauren Parry. I am just going to move. There we go. My name is Lauren Parry. I'm a GP. I'm medical director for Taurus. Taurus Healthcare is a GP federation in Herefordshire. We cover the whole of the county, and Herefordshire's got a registered population of about 200,000. And we're split into 5 PCNs and 19 practices. We're quite a neat and tidy county from a population health management perspective. We've got 1 community trust, 1 acute provider, 1 council, 1 mental health provider, and all the GP practices are part of the federation. So we've been working on our data analytics for quite some time because we're really passionate about being data driven in the decisions that we make. So we've developed data and analytics expertise. And what I really want to talk to you today about is the rich and powerful and enormous data set that we have in general practice and in wider primary care. In general practice, we're coding demographics, risk factors, long-term conditions, social circumstances, hospital admissions, ED attendances, and all of that data set is sitting within your practice, within your PCM, within your neighbourhood, to really understand how you can then have an impact across your population. And Primary Care Analytics is a subsidiary of our federation. That is our data arm. And we've developed a tool called Population Health Management Plus, which is using our general practice data and combining that with nationally available data sets. And we've been working with our data scientists, data analysts, and public health colleagues to really champion general practice's ability to lead the way in population health management. So we touched on earlier about making sure that we're all fit for the future. The 10-year plan, which was much anticipated, is now out and is really, I think, an opportunity for us in general practice to really understand actually the importance of care, with that phrasing of hospital to community and treatment to prevention. The neighbourhood health model guidance there, I've just picked out those 3 key areas which are all about us really understanding our cohorts of the population, and really then helping us to understand how do we evidence as a practice, as a PCN, as a wider provider, that we're doing well and the part that we can play in the system. I also think if you're a network where you're maybe not sure where best to work together, recognizing that this language of neighborhoods is threaded all the way through the 10-year plan, actually data can help you to unite in a common purpose. So I'm going to give you some examples of where we've used our PHM tool. So towards the end of in the pandemic, we were looking at tracking our COVID vaccination rates, and we were using our population health data to really understand the cohorts of the population where we were not reaching good vaccination rates. And by understanding the characteristics of that cohort, by understanding where they are located in our county, it helped us to really target our interventions, target our material, target where we put our clinics. And because of that, we had one of the highest vaccination rates in the county. One of our PCNs really wanted to understand its high intensity users, and using data and looking across the population, it understood that actually fibromyalgia was an underserved population within their PCN. And they were able to look, and they were high intensity users, but actually had low satisfaction rates. Working with about a cohort of 96 people with fibromyalgia, they were able to develop a series of education sessions, both in person and online, and personalised care plans. And that enabled them to not only have better health outcomes, but also reduce the intensity of appointment use in general practice. Then we've used our population health data to really understand health inequalities. So in Herefordshire, we are really good at cervical screening rates. But when we looked across the whole population, we identified that actually we were not reaching our Indian, Pakistani, and Bangladeshi women. And because then the numbers in each practice were quite low, you couldn't identify them easily within a practice. But actually, by looking across the whole population, we could see that we were absolutely not reaching these important people in our community. And it's enabled us to then take targeted approaches to really explore with that community why we were not reaching them, why they were underserved by cervical screening. And by really understanding that data, we've now improved cervical screening uptake. We've also been working with our geriatricians. So we were invited to a geriatrician, so general practice was invited to a geriatrician away day. And they really wanted to understand where would they best add value for frailty in our population. And we looked at heart failure, for example. What we could see was heart failure made up a large proportion of our admissions. The waiting list for our cardiology is really long at the moment, whereas actually our geriatrician appointments are underutilized. So we were able to understand actually if it would be better for patients with heart failure and a Rockwood score over 6 to be seeing a gerontologist rather than a cardiologist. And by identifying that population and being able to track the outcomes that we were looking for, we've been able to reduce their cardiology waiting list by putting them into and maximizing utilization of the geriatrician clinics. So before I hand over to Paul, the final thing I wanted to talk to you about was how we used our tool at our day-to-day. So I mentioned before, we are really leading the way around neighbourhoods. We really want to be data-driven in Herefordshire, and we really want to understand how do we work better together as a system. So we brought together our primary, secondary and community care colleagues, both managers and clinicians, with ICB colleagues, data scientists, data analysts and public health colleagues to really start to understand the cohorts in our population. So we wanted to understand, we've got a real burning platform. So we have, if we don't change the pattern of admissions, we are going to have to build 3 new wards at the hospital by the end of 2026. So we can't do that. There isn't the space, there isn't the money to do that. And actually what we know is that we're not admitting all of the right people. So we needed to look at that. So we wanted to understand the cohorts of patients that are being admitted multiple times. We also know that people with frailty, often hospital is not the right place for them. So this conversation between looking at the evidence, talking between clinicians and public health colleagues about where could we add value? How do we make sure that we are targeting the right people? We know that patients with frailty who are admitted to hospital may get acquired functional decline. They may come out with more dependence on services than they had when they went in. So we wanted to look at admission alternative pathways for them. We also had a contract whereby we were looking to see actually if PCNs could focus on more intensive work on a particular cohort, where should they focus? And this isn't about us stopping people going to hospital. This is about making sure that the right people are seen in the right place. So if I look at this cohort, we are looking here at patients who are over 65 and have had 3 or more admissions. Now, if I look at that data, so what you can see on each of those lines is our different PCNs. So just trying to understand for older adults with 3 or more admissions in the last 12 months, we can see that actually there is variance around our PCNs in terms of demography. So the top PCN seems to be disproportionately weighted towards those in higher IMD groups, whereas the second PCN in the list is it seems to have their higher utilization is in people with lower IMDs. If we look at Rockwood scores, you can see that for the North and West PCN, you've got patients with sorry, my screen is very small where I'm working, and I'm just trying to check that I'm giving you the right slides. The Rockwood score is different in the different PCNs. So if you were doing this based on a hunch, you might think that this is just about frailty. Whereas actually, by looking at the data specifically, we were able to understand that actually each PCN needed to take a different approach for the people who were using the hospital, who were being admitted to hospital more often. We need to take a different approach, and that is data-driven. Here, if we're looking at patients, so here's our whole population. So using our tool, I'm looking to see patients who have got heart failure, and I'm looking to see the patients that are also housebound. We're trying to understand where would we best add value, where would we best target our services. And if I look at continue to revise the cohort and looking at patients with a Rockwood score of over 6, we're starting to see where our final cohort might need to be. If you're developing a service that is about patients who've got heart failure and might need to see their geriatrician, if you've got a proportion of your patients who are housebound, they're going to have a different service needs than patients who are not housebound. And all of that data is sitting within your general practice data set. And if you look at what's just come up in the circle there, this is the number of times this cohort is having interactions with a GP. So this may not be admissions, but it might be a GP looking at test results, or a GP looking at letters from the hospital. They are using a massive amount of appointments compared to the average population. So actually this was really helping in the narrative for our PCNs, who are saying, well, actually, if we were going to, we can't just keep doing more. But actually, you already know that you're seeing those patients a lot of times. And actually, by really looking at how you're seeing those patients, you can then decide we could make each of those contacts more valuable and have a greater impact. It also helped us to understand that in lots of our practices, patients who are housebound were being seen either on a duty list with no continuity of care, or maybe seen by the GP registrars, or by an advanced practitioner, and actually with some of the most complex of patients. And it helped us to identify that these patients might need continuity of care, and actually we need to be looking at them differently. So in all those situations, you're using the PHM tool to identify your cohort where you might want to work differently for. So I will hand over now to Paul.
Hi, so I'm Paul. I'm part of the team here at Primary Care Analytics. As Lauren introduced us, we're part of a GP federation. I think for a long time, we've kind of recognized the value of data and the richness of primary care data in particular. So we've kind of built up our local function to include data analysts, data scientists, to really kind of maximize the value of that. I think then we kind of recognized that there was perhaps a bit of a void nationally around primary care data. So we started PCA to really support other practices, PCNs and federations. As I say, we're sat on one of the richest sources of data across our healthcare system, and yet more often than not, I don't think we really make the use of it. Unlike other models, we believe that just dropping off-the-shelf products on their own doesn't really maximize the impact. But having named analysts to work through data and dashboards tailored to your locality and to support you on your journey provides a much better outcome. So the tool that Lauren's been using on the last couple of slides, this is our PHM Plus dashboard. It utilizes a huge amount of data, pseudonymized data from general practice to provide a complete overview of the population. The tool brings together more than 50 million data points from our population in Herefordshire of around 200,000 patients, information on demographics, deprivation, health, and long-term condition data, admissions, GP appointments, contacts, a huge amount more as well. It also includes some of the other data captured by general practice, so whether someone's housebound, has falls, anxiety or depression, whether menopausal, veterans, carers. I think it helps us to really kind of make sure that we're providing something more than just a medical model in there. So all of the data within the tool is filterable with just a couple of clicks to identify your criteria. The dashboard then instantly reloads to show you how many people meet the criteria, where they live, their demography, deprivation, number of contacts, GP with a GP, how many times they've been to hospital. What we find is if you pair this tool then with a really experienced analyst who understands primary care data, has familiarity with the data sets, and is able to work with your teams in their meetings on the fly, this becomes a really powerful tool able to help drive population health and risk strat locally. So our experience locally and with our other customers kind of really demonstrates that these two-way conversations between analysts and subject matter experts make the difference. And furthermore, kind of our ability to tailor the tool to local PCNs, local federations and neighbourhoods enables you to bring in local data, customize the tool to your need, look at other elements of coded data that we wouldn't ordinarily look at. So in short, we turn 50 million data points with a couple of clicks and the support of an analyst into actionable insight. We use pseudonymized data, reducing our exposure to PID, helping to manage risk with practices. Where practices and PCNs want to actually know who meets the criteria in their patch, we're able to support with the clinical system searches. We find this strikes the best balance for practices and their IG. As you can see from the animation that's been scrolling along, there's a lot of information on the homepage, but when you start to work through it, it becomes really intuitive pretty quickly. Starting at the top, we have filters for demography, long-term conditions, coding, contacts, which instantly change the cohorts, and see a range of information, including cohort size, demography, ethnicity, inactive patients, average GP contents, practice and PCN populations, long-term condition numbers, overlapping long-term conditions, and trends on numbers, as well as segmentation by long-term condition and age. We deliver all of this using coded GP data, no waiting for a data lake to be built locally or expensive risk strat tools. Instead, you've got ready access to a tool based on the rich data set from general practice with local flexibility, which can really help you lead the development of your single or multi-neighborhood providers. So this is just a quick demonstration of our PHM Plus tool with some tangible examples from Lauren as to how we've used it in our local home federation. We're really keen to support other neighborhoods on their PHM journey. Yeah, so if I pass back over now to Claire.
Yep, fabulous. Thanks very much. Thank you both. That was really interesting. Yeah, as Paul was just saying, so Redmore Health and PCA, we are teaming up and offering a variety of joint support packages designed to help practices, PCNs and ICBs with population health. So if you want any more information on them, please pop us an email at our support address. Just to say before we move on to the Q&A, all of the resources that you might find useful from today's session will be on our D&T network. We will pop them on there, and if you're not already on the network, after today's session you'll receive an invite to join, so you'll be able to see all of that there. And a quick reminder, I think we might just turn cameras and mics on for people, and then they can ask questions in person if you like. If not, you can pop any questions that you've got in Q&A. There we go, and we'll move on to the panel. So are there any questions in the chat? I'll pop my camera on as well. Are there any questions in the Q&A? The moment, no questions yet. I was going to ask a question. I don't know who. Jeremy, do you want to answer first? What is the biggest area that you've seen from a population health discovery that's made a difference in a practice? What kind of area have you looked at?
It's probably some examples from Cornwall, where they've been working more as neighbourhood teams over the last couple of years. Like they started off just using their clinical knowledge of the patients, but what they found was that they were still missing quite a lot of people that weren't because they weren't presenting at general practice, they were presenting elsewhere or just not presenting at all, or they were in nursing homes, for example, and just weren't getting onto the radar. So when they started actively looking for people, initially they just did things like organising better the way they supported nursing homes. So they didn't use sort of tools or anything at first, and then they started to identify people who actually did need support, and their aims of doing that were kind of twofold. One was to, apart from the obvious ones around better patient care, to reduce demand on the practice for sort of a GP future GP appointments and out of hours demand. But also admissions to hospitals, because in Cornwall they were kind of being incentivized to reduce hospital admissions, and so they were quite successful in doing that. They were able to see both a reduction in kind of out of hours contact and hospital admissions, and now they use this tool, as I mentioned, that's called Brave AI, which kind of automates the whole patient finding process using it. Using data mainly from the GP practice, and that's thrown up some more patients that they weren't aware of that they've been able to work with. So they are beginning to see reductions in utilisation, but it does take time. It's really notoriously difficult to prove. There's so many other things going on at the same time. But I don't know, but I'm sure Lauren's got some great examples as well.
I mean, I think it is. I think understanding it in that framework is really helpful. There are those things where there's already what we know, and the data can help us with the bits that we don't know. I think cardiovascular health is something that is really important in trying to change the tide for the population in terms of use of secondary care services. And actually you can start to track that data, track the changes in your population, and so it can help you target care more upstream. So and I think that's why general practice data is so important in understanding those risk factors and understanding actually both at a system level and then being able to drill down into the patients, the individual patients. And I think that's important for any tool, that you've got that ability to look at the whole population in a pseudonymized way, but then be able to identify, okay, so who are these 10 people that we're talking about? And that's really important for a practice.
Well, I just add something else. So I totally agree, Lauren. And diabetes or pre-diabetes is kind of a brilliant example of where you can make a difference quite quickly. And using tools like the primary care analytics, you can create a manageable list of people that are pre-diabetic but might not have been seen for 12 months or for whatever reason. And you can quite quickly reduce. You can help people who are pre-diabetic become not pre-diabetic, and people who actually are diabetic become pre-diabetic or not diabetic at all, just through some simple interventions around diet and exercise, over quite a surprisingly short time scale, which then has a massive knock-on in terms of avoided future ill health and contact with the health service.
Fab. Thank you very much. Are there any questions that anybody would like to ask? Because I know I'm hogging the question spotlight at the moment. If you want to put your hand up or pop something in the chat or the Q&A. I think there's a question from Lisa. Have either of you created or seen a top 5 things to do first and a how-to guide? We got a top 5 things somewhere.
I think it's identifying what the top 5 things what are you trying to achieve? So are you trying to change, improve access by changing appointment utilization? Are you trying to prevent admissions? Are you trying to improve the the health and well-being of a particular cohort of people. And then I think once you've understood what you're actually trying to do, then you can drill down into the data. An area we looked at, for example, was patients with COPD. So I think across the country, people with COPD and heart failure make up a large proportion of people going into hospital with acute admissions, which if you can see that they have deteriorated over the previous few days or weeks, and actually an intervention earlier would have meant them not turning up in ED in that position. So we started to look at data where you had patients with COPD who'd been admitted the previous winter, and making sure that they were empowered to manage their condition better in the summer and autumn of the following winter, and able to identify the markers when they were deteriorating, and then wrap care around them. And by then sort of focusing on, we have been talking in Herefordshire about doing a lot for a little and a little for a lot, and sort of trying to move away from this feeling that every patient needs the same level of care, the same long-term condition annual review. Actually, if you look at your data of the people who are exacerbating with a long-term condition, they need a different approach to people who are managing well of their own condition. So I think if you can pick up some of those themes and then target your intervention like that. But I think it is helpful to have to think about how would I approach population health management from the beginning, and really happy to think about how to guide outside of the webinar.
Fab, thanks. Jeremy?
Yeah, similarly, I don't know of one that's kind of already in existence, maybe, but I'd be happy to help with that. I mean, there are some common things to look at, but you may have worked on them already, so I guess it would be probably more than 5. It might be 10 or something, because you'll have done some of them already. So things like missed opportunities to help people with diabetes, things like how are you organising yourself in terms of looking at people in nursing homes, those kind of things. But can't give you an answer straight immediately.
Fab, thank you very much. So we've not got any questions in the chat. So what I'll do is I will wrap up at the moment. If you've got any questions, or you just didn't want to come on and ask the questions, you can start a conversation in our D&T network, and Paul, Lauren and Jeremy will hopefully be on there as well, and we'll answer them for you. So I'd just like to say thank you very much to Jeremy, to Paul and to Lauren for joining us today. And thank you very much for joining us as well.